Welcome, everybody. My name is Pam Fury, and I am Assistant Manager for Clinical Documentation for Alameda Health Systems. Today's subject matter will be sepsis. As you're all aware, sepsis guidelines and requirements for the documentation of sepsis has been changing over the last year or so. So we're going to pay particular attention to some of the changes in the new clinical evidence that's required to be documented. But I'll first start with, as a review of the medical records by the clinical documentation staff, what we find is the biggest challenges we face when the medical staff documents sepsis and what we need to address in our queries to the medical staff. So one of the first challenges is we'll come across a note that will state, patient meets sepsis criteria. That is not an acceptable diagnosis, even though the word sepsis is used. You must document a diagnosis of sepsis in the problem list. Just documenting a narrative of patient meets sepsis criteria is not acceptable. Also, we will come across a note that might state sepsis protocol initiated. Same rationale as the first one. We must have you document the diagnosis of sepsis in the problem list. Even though you did initiate the sepsis protocol, that doesn't suffice as a diagnosis. Another thing we'll come across is a finding where there will be documentation in the H&P and only one progress note and the H&P, but it's not followed through the medical record. Of all the diagnoses that must be followed through the medical record, in each progress note, you must carry the diagnosis of sepsis through the progress notes until and including the discharge summary. Now, you can write throughout sepsis resolving, sepsis resolved, throughout the medical record, but you must write the diagnosis throughout the medical record and then on the problem, or on, I'm sorry, on the discharge summary. Which leads me to the next one, which is we'll have a finding where you might document sepsis one or two times and not throughout the medical record. And it's not obvious if the diagnosis was actually ruled out. So if you do suspect it on an H&P and maybe the first progress note, but you don't suspect it after that, you must document sepsis has been ruled out. It's very important. Otherwise, we'll have to query. Another finding that we'll have is that the diagnosis is actually documented. Um, I'm sorry, that the patient, we might find criteria for sepsis in the medical record because we don't just read the diagnoses that are written. We go through lab results, radiology results, symptoms. We read all the notes and the medical record. And sometimes the clinical documentation specialist will find that a patient meets criteria for a certain diagnosis, and in this case, sepsis, but you haven't documented it as a problem in the problem list. So we'll query for that. And lastly, which doesn't happen as often anymore, but urosepsis is absolutely not a diagnosis. It needs to be separated into two diagnoses. So you must document two separate diagnoses on the problem list, which is urinary tract infection is a UTI and sepsis is a separate problem. So that's the majority of the reasons for our querying the medical staff for sepsis. Now I'm going to take you through what your options are for the diagnosis that you'll see on the query that you can choose from. So we will fill in all the clinical evidence for you. We'll fill in your treatment for you. We'll fill in any risk factors. But what needs to absolutely be documented is sepsis as evidenced by the criteria, and we will have the criteria listed, but you need to say if it's QSOFA, SOFA, or SIRS criteria. In addition to likely due to the underlying infection that you suspect. So it could be a UTI, it could be pneumonia, it could be a wound. And you can also likely due to UTI resolving or resolved. And the third component that's mandatory is with organ failure related to sepsis, and then you need to name the organ failure. So it could be AKI. So your diagnosis will read something like this. Sepsis as evidenced by QSOFA criteria listed above, likely due to UTI with AKI related to sepsis. That's a perfect sepsis diagnosis. So there's three components when you write a diagnosis as sepsis. then you might get a choice of the patient might have SIRS, right? So it could say it might not have sepsis at all. And whatever you answer this query is perfectly acceptable. You might say sepsis was ruled out, but patient had SIRS due to a non-infectious cause with acute organ dysfunction, or the patient could have had SIRS due to a non-infectious cause without the acute organ dysfunction, or perhaps the patient just has bacteremia without sepsis, or you're clinically unable to determine, or there's another diagnosis. But those will be your options on your query that you can choose from. The guidelines for sepsis. We're going to cover this. I'll cover this pretty rapidly, but the sepsis 3 criteria is what is being used now. So it's the SOFA criteria, but there are two different types of SOFA criteria. So if it's a non-ICU patient, the Q SOFA or quick SOFA is indicative of sepsis if any two or more of these three items are met and there is a suspected infection that's underlying. So the criteria now is the respiratory rate greater than 22? Does the patient have a blood pressure with a systolic less than 100? And is there altered mental status with a Glasgow score of less than 15? And then a suspected infection. Then you can document sepsis as evidenced by QSOFA criteria. And you don't have to list them because we have them listed in the query, or you can reiterate them. The other criteria if a patient is in intensive care, you can use the sepsis 3 SOFA criteria, and which covers a body system, right? So you just need two or more of these following criteria to be met, plus a suspected infection. So for the respiratory system, to have a PF ratio less than 300, which is calculated by the PaO2 divided by the FiO2. Now remember, these are ICU patients, so you'll have these parameters available to you. Cardiovascular system, to have a systolic less than 90 or a MAP less than 65 that requires vasopressors. You could also have criteria evidence that's hematologic, which is a platelet count less than 100,000. The renal criteria is a serum creatinine that's greater than 1.2, or a urine output that's less than 0.5 milliliters per kilogram for 2 hours. Or for mental status, you could have a CNS system with a Glasgow less than 15. Hepatically, you could watch for a serum total bilirubin greater than 1.2 milligrams per DL. And then metabolically, you can watch for a lactic acid greater than 2. Again, when a patient's in ICU, you have these criteria available to you, these clinical indicators, and you only need 2 of the 7 that are listed here to meet criteria, plus a suspected infection. Now, there are different definitions. There are definitions for sepsis 3, definitions for sepsis 2, and definitions for septic shock. So the definition of a sepsis 3, which is the newest criteria that's evidenced out there, is sepsis equal a suspected infection plus the QSOFA or the SOFA criteria and a mortality indicator, which is organ failure. And organ dysfunction, I didn't mean to say organ failure, organ dysfunction. Organ dysfunction can be identified by an acute change in the total SOFA score greater than 2 points. But examples of organ dysfunction are the following: respiratory failure, acute renal failure, acute liver failure, coagulopathy, thrombocytopenia, acute hypotension, or an acute change in level of consciousness. So if you remember to the first slide, you must indicate the criteria used to diagnose sepsis, the underlying infection, sometimes it's multifactorial, and the organ failure that is likely related to the sepsis, but you must list the organ failure. All 3 have to be present in order to meet the definition of a sepsis 3 criteria. Now, AHS adapted the SOFA criteria in March of 2017. But it's also been adapted by many payers, RAC, SSC, and some payers, and it was published in the JAMA publication of February 23, 2016. The only payer, which is a majority of payers in a lot of cases, that did not totally adapt the SOFA criteria, that still uses SIR criteria, is CMS, and that's Medicare patients. You all cannot worry about it. which payer the patient is as a physician. However, I would like you to keep in mind if you can document that they meet the QSOFA criteria and 2 out of 4 SIRS criteria, that's very, very helpful, and it covers every patient regardless of payer. They've made it very complicated. The definition of sepsis 2, which was historically was always used up until the last year or so, was SIRS due to an infection, either suspected infection or a confirmed infection, which didn't exclude SIRS that was due to other causes. So sepsis 2 definition was sepsis equal a suspected infection plus SIRS, but it had to have 2 out of 4 criteria. Now the definition of septic shock is the above with sepsis, plus you have persisting hypotension that required a vasopressor to maintain a MAP greater than 63. Okay, so I want to repeat that. To diagnose septic shock, the definition is having sepsis plus persisting hypotension that required a vasopressor to maintain a MAP greater than 63. Or you could have sepsis with a serum lactate level greater than 2 despite your adequate volume resuscitation, meaning you tried to resuscitate the patient with fluids, but the serum lactate still was greater than 2. Okay, now what I'd like to cover here is the sepsis guidelines, which are published, and since it's been adopted by AHS, this is a screening form that's actually used in the ER and in ICU. And so the guidelines are sepsis that are associated with acute organ failure determined by the 2-point change in the SOFA base. So you can see here under B on this form, it gives you a checklist for the screening criteria when a patient comes either through the ED or into the ICU with the 3 criteria that I mentioned, altered mental status, systolic pressure, and the respiratory rate. And then if the QSOFA score is greater than 2, they would go down and complete Section C, and this causes a flag for sepsis in the medical record for the physician and to initiate treatment with the standard AHS protocol. So if there's 2 out of 3 of the QSOFA, then you go through and then you evaluate for the complete SOFA by body system. And then the third international consensus definition for sepsis and septic shock are indicated below, and that's just the definition and their criteria that came out of the article that was written by the third international consensus definition for sepsis and septic shock, just for you to have as your reference. And that's what we have about sepsis. Sepsis is probably one of the highest query rates of all the diagnosis because it gets somewhat complicated for physicians to make sure they include all 3 criteria in their diagnosis when they diagnose sepsis. And as always, thank you very much for your great clinical documentation. We're partners in this process, and you can always call the clinical documentation department. And the tip sheet that was provided to all of the physicians has the sepsis criteria outlined very clearly in that laminated pocket guide and tip sheet. Have a great day. Bye-bye.